Wanted to thank everybody for joining today. I'm your general contractor and host, Mike Krupa. I think you know the background on me at this point. As a reminder, make sure if you have questions that you're entering them into the question bar or the chat bar, and we'll make sure that at the end of the episode, both Bruce and I are going to stick around for an extra 15 minutes and answer questions if you do have any. The last thing is that these episodes, as you know, are eligible for HRCI and SHRM credit. So same thing, after I'm going to send everybody the webinar, and if you need those codes, feel free to just let me know and I'll forward them on. We have a couple episodes left in the series. We're going to be meeting with Rhea Campbell from ImagineMD. Next episode, we're going to do a second deep dive into ImagineMD, and then we're going to cap it off with some really exciting data on a case study that implemented all of the different partners that we're going to talk about throughout this entire series. As a reminder, this webinar is really set up to teach three things: how to avoid being surprised by your health insurance renewals, teach you how self-funding will lower your costs with some of the different solutions that we have been interviewing, and then how to make your benefits more competitive at the same time. Today we're talking about how your ID card, that medical ID card on your health insurance plan, really acts like an unlimited company credit card. And we're going to talk about how you can implement some spending limits that really protect your health plan and protect your members at the same time. But first, we're going to do a quick refresh on the problem and then the solution with the remodel health plans process. You know, we talked about this in the first episode in detail, so I'll just hit on it high level. But, you know, the healthcare system is really stacked against us right now, and that's why costs seem impossible to control. You know, I talked about how the medical loss ratio that was included in Obamacare really drove incentives to increase costs, and that's what we've seen, and the carriers are who is benefiting from this. And second, we have this PPO network where we got every single provider almost in a network, and members don't have cost and quality tools yet, really good ones, at their fingertips. And that causes this huge disparity in pricing for the exact same procedure. And then finally, what we're going to spend a lot of time talking about today is how your employees really see an unlimited company credit card. They have a built-in out-of-pocket max, but outside of that, you pick up the tab, whether that's through your fully insured premium or your self-funded claims, and people can go wherever they want and pay, really, you pay the difference for what that's going to cost. Those are your large claims. And so we're going to do a quick refresh on the remodel health process. Most employers out there today, your health plan looks like the one on the left. It's outdated. There's design flaws that need to be fixed, and employees don't like it. That was my bathroom a couple of years ago. Me and my wife hated it. Design flaws were leading to a leaky shower. And when I started doing the demo, I started collecting data and understand why things weren't working the way that we wanted them to. And you can do this same process on your health plan. It means you got to create a long-term strategy. You got to start looking at data on your health plan, understand why things aren't working the way that you want. So quick refresh on the remodel health plans process. You have to establish control within your health plan. That means creating a long-term plan. That means collecting data on your plan and understanding what's going on so you can target solutions. And that means eventually, this doesn't have to be right away, but eventually you're going to want to get into a self-funded health plan. That is going to give you the ultimate control to align your health plan with partners that have your best interest in mind. That could be a medical partner. That could be a pharmacy partner. That could be somebody to help you manage your large claims, but you got to start aligning your plan with the right partners, and self-funding will let you do that. But lastly, don't forget to reward your employees. That's how you get them to love these types of plans. And we found the best way to do that is to make things free when they make good healthcare decisions. So before I introduce our next speaker, and Bruce, do we have you on now? Everything all good? Can you hear me?
Yep, I'm on. Just had to figure out how to mute myself.
Perfect. Bruce, there's go ahead and turn your webcam on too.
Okay.
So people can see you. All right, great. So before, I got a blank screen for you there.
Uh-oh.
So while you figure that out, before I introduce Bruce, I want you to think about something here. I want you to think about your credit card statement and pretend like you just get your bill. And the only information you get is the amount that you owe. There's no transaction backup at all, and to top it off, the bill is double than the prior month. How would that make you feel? Probably not good. I would say that is unacceptable for most people. Or think about this. Think about you get all the backup, and you notice that half of the charges on there never even occurred. Would you pay the full balance, or would you try to fight the credit card company? If I'm a betting man, you would probably fight that all day long. But that's what's happening on employer-sponsored health plans all over the country today. And that's what we're here to talk about. We're here to talk about how you can actually do something about that. And so with that, I'm going to introduce Bruce. Bruce, you know what? I'm not seeing you on the camera here, but I got your mug shot up here so people know who you are. We can kind of just go there. But Bruce, could you just do a quick introduction? And you know, you're with ClaimDoc, obviously. Who's Bruce Hansen? What do you do, and who's ClaimDoc?
All right. Well, thanks for having us on, Mike. Sorry about the webcam. It's probably better for everyone out there that face isn't on, and this one where, you know, a professional photographer makes me look good does. But again, I'm Bruce Hansen. I'm Executive Vice President with ClaimDoc. ClaimDoc's been around a little over 10 years. It was started by Ben Crambeck, and it's still a family-owned business. We do medical claim auditing, and member advocacy is the core of our business. Most people know it as reference-based pricing. My job at ClaimDoc, I've been here about 6 years as Executive Vice President. I move across the company to the various departments, making sure that our initiatives are being put in place and executed, and really making sure we stay true to the mission that Ben Crambeck, our CEO, has put in place to create affordable and sustainable healthcare alternative to networks. And we do that with reference-based pricing as the fundamental financial mechanism under the programs that we provide to clients.
Thanks, Bruce. Right, so that's obviously what we're trying to teach employers here is how self-funding can lower your costs, and this is a great solution to help lower your costs. That's the problem most employers are facing. It's a problem ClaimDoc is here to help us solve. Bruce, the next page here, I just have a quick highlight of some of the core functions of ClaimDoc, and I want to spend, you know, the majority of the time talking about these core functions here. You know, the first one being your audit function. I talked about, you know, the credit cards and how consumers would find that type of behavior completely unacceptable. You know, the fact is you can correct me if I'm wrong here, but I think the statistic is that 90% of all hospital bills have an error on them. Can you talk about your audit program and what it does and how it does to address this big issue?
Well, our senior audit manager, we hired her about 4 years ago from a large regional accounting firm, and she was running their healthcare consulting division, and she's pretty conservative. Our sales team want to call it fraud. She calls it mistakes. And you know, the sales team likes to make things sound a little better, but our whole point if it's happening over 90% of the time, can you really call it a mistake at that point in time? But it's really rooted, and I think you've hit on it maybe in other webinars, but it's really rooted in those large network contracts. And the escalating cost of healthcare is driving through those cost of claims. And the first line of defense is if you're the facility and you've had somebody go through a knee surgery or anything complex, you have a team of nurses in there and people trying to get it right on what should we charge for, getting those bills right. But there's an entire industry built on upcharging for the revenue cycle management at those hospitals. So that's the big indicator for all of us, that if there's somebody on the offensive with the billing and coding practices, plan sponsors need to be on the defensive. Because what's in place right now at this point in time, through our data, we're seeing that commercial payers, commercial plan sponsors are paying 3 times what Medicare is paying. And it had, the last 5-6 years, had been running around 220 or a little over 2 times, 2.25 times Medicare. It is starting to really ramp up. And so our first line of defense on that is the audit. And that's where we put eyes on these claims. We get the itemized bill. We have nurses and coders that review them for exactly what those entities are that are trying to drive up charging, and they're reviewing for billing and coding errors, and they're reviewing for medical necessity. And I think maybe for a really simple view of that, think about COVID. And I think a lot of people know that the government put in place a program where hospitals had an upcharge or a booster. So if they put on a bill that it was COVID related, I think they got automatically 20 to 25% more on that claim. So what our coding team and our audit team was really invested in doing is they were getting pre-op blood work, they were getting intake information to look, is there anything in this related to respiratory issues? And if there wasn't, they would go back and they would challenge and they would look for more information. So that was a big part of our job during COVID. A big part of our audit work was exactly that, saying, no, you're just trying to get this through to get the booster. Our plan sponsors are not responsible for that, and we're going to get that removed.
Yeah, that's interesting, man. I had my own COVID bills that happened as well. I think a good exercise for the employers that are on the phone today. Here's what I would suggest. I went through this myself. For you to just get an idea if this is even happening or not. I mean, it is happening, but to give you a better idea of what things look like is next time you go to the hospital or you have someone in your family go to the hospital, request an itemized bill, right? All you get from the hospital right now is basically the bill with some high level information. There's not the transaction data behind the scenes, but go request that. I mean, it's things like the doctor said that they were going to order an antibiotic, and as you progress through, turns out that antibiotic was never ordered, but they still charged you for it on the itemized bill. Those are the errors we're talking about. I would highly suggest everybody goes through that exercise to see what kind of things that you might find there. So thanks. Go ahead.
Yeah, and the other aspect there is just creative billing practices that your typical person won't be able to find. And it's called unbundling. So a lot of the services that people go through, especially with inpatient stays, there will be a bundled rate that Medicare has put together. So if you go in for a specific procedure, as opposed to having everything down to the Band-Aid and the pillowcase a separate charge, they'll just have a one bundled charge. And so our nurses and coders understand that bundling package. But then what you'll find through those creative billing practices, they will then slide in there items that should be considered part of the bundle. And I relate it back to people. It's if you buy a car and then you get the full invoice for the car. You buy a brand new car, you're buying the car, and then you find within there, they've also charged you for the tires, they charge you for the steering wheel, they charge you for the transmission. It's like, no, that's part of the full price of the car. You don't need to then tack on those extra charges. So the audit work we do is really critical to the entire process, and I think it aligns really closely with that, just the concept of we have to keep an eye on our credit cards these days, especially with the amount of identity theft that's going on out there. It's really no different. You have to be good consumers. And that's hard in the healthcare space for most people to be, and that's why we have our audit team to do that for our clients.
Thanks. That was a good example of the card too. So let's hit on the next one, reprice and reference-based pricing. And like I want to be clear here. Like we could talk about reference-based pricing and what it means for probably about a good hour. So Bruce, give me like one or two sentences on what is reference-based pricing. And how does it compare to like a Blue Cross, right? What's in its most basic format?
You bet. Yeah. Reference-based pricing, you hear it used generally as a way to replace a network. But when you hear reference-based pricing, that is purely the repricing mechanism. That's the financial mechanism that will drive a bulk of the savings. It's instead of when the TPA gets that claim, instead of bouncing it off a network, instead of the Blue Cross network telling them what to pay on that claim, they utilize a system. So they'll send it to a vendor, and that vendor will then look at typically a Medicare markup. So instead of getting a claim for $30,000 and applying whatever the discount is the network says, so 50% down to 15, a reference-based pricing or a repricing model will instead look at what is a baseline price for that, whether it be a Medicare rate or a cost of charge that a hospital is submitted to CMS, and then they'll mark it up for a profit margin for that hospital. So it's really a bottom-up pricing mechanism as opposed to really a made-up discount off a made-up number.
Yeah, it's so like, I as someone with an actuarial background, I think the frustrating part of these network contracts with Blue Cross, Aetna, Cigna, you name the network, is they're opaque, right? None of these carriers actually will release specific contractual information, so we have no reference point. But Medicare is the largest purchaser of healthcare in the world right now, and that is a very solid reference point to say we're going to pay off of that. That's somewhere where we can actually look at and see what that contractual cost is first and then go from there. Bruce, I'm just going to say it. Reference-based pricing has some warts associated with it. There's two things that members deal with. They deal with access issues, meaning potentially getting turned away at point of service, or something that's called a balance bill, which for the audience, a balance bill, it could be happening on your Blue Cross plan today, but essentially what it is, we're paying a reference price, which is in most cases lower than what the hospital is getting through their Blue Cross discount. And so what the hospital may do is say, no, we want to collect the full amount, and so we're going to bill the member for the difference. That's what is called a balance bill. And those can be very disruptive to employees. Now, it happens less than 5% of the time, but when it happens, it can be disruptive. And so it's important that you have some processes in place to be able to handle that. And so, Bruce, we partner together because you guys do things a little bit different. Can you talk about how your advocacy program, let's start with the access. How does your advocacy program help with members getting turned away at point of service? Because if I was an employer, I would be worried about that.
Yeah, you're 100% right. And, big picture speak, from a big picture, people move to reference-based pricing because of the savings and the repricing mechanism. But if you're a plan sponsor, your members expect the whole thing to be replaced, the whole experience. They want the total experience. And what we really drive on is you can save money, but if you're not taking care of the members, it's not going to be sustainable. And so you'll get a short-term savings without the long-term sustainability. So we really hang our hat on the advocacy, and we believe that any entity providing RBP should. We call it pre-claim, so access. The number one issue, most members are used to having a Blues United on their card. They show up, it gets accepted, they submit claims, and everybody moves on. To remove the network and the financial pressure that networks essentially put on plan sponsors, if you're going to remove that mechanism, you then have to solve for access. Otherwise, members will show up. Mrs. Jones will show up with her kid in the front desk. The very first thing will be, we don't recognize this card. And so to solve for that and make the experience smooth, we utilize what we call a pave the way program. We don't want Mrs. Jones to show up at that doctor's office and have the hurdles to jump through and be required to understand the payment methodology. So what we do is we proactively get a list of the physicians that your members will see, or the physicians of our plan sponsors. We also ask them to submit nomination forms of physicians that they anticipate seeing, and we do proactive education to those providers. We don't want this to be an adversarial relationship. We know 90% of the providers out there understand things are broken, and they actually are looking for alternatives alongside of us. So we've taken the approach, which is really unique in the space, because it's a lot of hard work. It's hard finding the right people to talk to, where we call out and we educate that provider. And we say, you have a patient there, Mrs. Jones, she would like to come see the doctor in 2 weeks. She's had a change in her medical insurance. Let me explain to you how this works and how you will get paid. And so that's been our
At the end of the day, that's what they really care about as a provider, right? Is how they're going to get paid, and rightly so. They're performing a service, and they should get paid for that service.
100%. And so that's the approach we've taken, is just proactive provider education, helping them understand the progressive approach that Mrs. Jones' plan sponsor and her employer is taking to healthcare. And again, 9 out of 10 times they appreciate it, and they enjoy working with us, because they get tired of all the credentialing and all the work that goes into being part of a network too, and the submission of claims and how long it takes to get paid. So they're excited about new ways of seeing patients that way and new ways of getting paid. There are times where, you know, it's a really disjointed system, and sometimes we have to explore single patient agreements or longer term contracts. But we kind of keep those in our back pocket, because we know our clients have really joined us due to the financial advantages we can drive of getting them out of that world of networks. So we put in place that Pave the Way program to smooth those access points out.
Okay. Thank you. Yeah, and I've seen it firsthand. I mean, members can nominate any provider, and it works. It works to do it ahead of time. We've seen significant improvement. You know, we got about 3 minutes left here, and we're going to talk about balance bills next, and that could go on forever. But just very, very high level, quick. What do you guys do if a member gets a balance bill, and how do you protect them?
Yeah, the biggest thing is that they communicate. You're not going to enjoy the financial advantages of a plan like this without there being a change. And one of the biggest areas of change is we're going to ask your members to communicate with us. Open your mail. If you get a piece of mail, if they get a claim or an EOB that says they owe money, don't pay it. Contact us, connect with one of our balance bill specialists. The very first thing they're going to do is review that with the member and ensure there is something above and beyond, or above and beyond patient responsibility. If it is above and beyond patient responsibility, that's where we step in. We have them sign an authorization that acknowledges ClaimDoc's going to dispute that with the provider on their behalf. Again, many times we can reach out and explain the program to them, because there could have been a mistake as they're reaching out, because again, they have complex systems. The billing person may have just identified this person isn't under contract, or they don't have them showing as in network, which we don't want them to be, and that automatically triggers sending out a bill like that. So it can oftentimes be education. If it goes further than that, we'll notify and re-educate. After re-educating the provider, We'll educate them on the appeal process they can go through to the plan. And ultimately what we do is we take the member out of the middle of it. And we say, if we have to even go as far as a cease and desist, but you're now working with ClaimDoc because that member signed an authorization for us to dispute this. You can't always account for bad actors, and we know those people don't always follow the rules, but the nice thing is we take that off the member's shoulders and we handle that for them.
All right, thanks. I'm gonna wrap up a little bit here. Look, I'm just gonna say too, like reference-based pricing ain't for the faint of heart. If you're on the phone, it takes a little bit of work, but we're adding spending limits, just like a credit card has a max that you can go on, right? Our max here is a percentage of Medicare. It's a known figure, has built-in profit margin. That's what this is doing, and we're auditing these credit card statements every single time they come through. And if you want that kind of protection on your plan, reference-based pricing could be right for you. With the right communication, it can be a wildly successful program. Bruce, I think you and your team do a great job of mitigating these access issues, these balance bills, but to be transparent to the people on the phone, like they're still going to happen. And so the next episode, we're going to focus on a solution that pairs up extremely well with reference-based pricing. We did an intro to it on the second episode. It's called Direct Primary Care, but we're going to talk about what happens behind the scenes with direct primary care and how when you pair it up with reference-based pricing, you can bring that noise to an absolute bare minimum to have this operate even more seamless than a Blue Cross, Blue Shield, or Cigna, or Aetna, or United healthcare plan. And so excited to talk about that. Bruce, just high level, if you could give me what could employers expect to save in a reference-based pricing scenario on their medical claims? What could employers expect to save?
It's going to usually be, we've seen in the 25-30% range is bottom line expectation. We've been looking at cost per covered employee, which ultimately is, what you're spending is what matters. And it's higher than that. And as much as our sales team wants us to keep quoting, it's been pushing over 40% on savings is what we've been seeing. But most employers would be happy with 25. So I'm going to under promise. It's going to be in that 25-30% range is what you're going to save.
Appreciate it. So employers on the phone, right? There's some warts associated with it. That's the potential though, and there's a lot of ways you can set this up in a great way. Thanks, Bruce. Thanks for joining. We're gonna let me just check here. I'm gonna see if we have any questions that came in. Okay, looks like we do have one question. Is there a way to get started without going all in? Bruce, I'm gonna start on that question. And so I think what the audience member is asking is, like, do you have to do this for everybody within the health plan? And I'll answer that is no, you don't. You can actually you can start by dipping your toe in the water with reference-based pricing. The easiest way to do that is actually something that's kind of being done on your Blue Cross United plan today, which is on your out-of-network coverage. You could add in reference-based pricing just on your out-of-network claims to make sure that those don't become huge, large claims. You probably only have 2% at most claims going out of network. That's a good way to start to dip your toe in the water. And then, step 2, I'd say, is offering or considering doing like a dual plan option. And that's where we can get into rewarding members for making the right decisions. And what I mean there is give them a network option for option 1, give them a network option for option 1, like just like they're getting today. Maybe it's Cigna or Aetna. You can take that plan, member ABC. Bruce, your camera just popped up. So that's one option. Option number 2, though, is implement a reference-based pricing plan and reward members for taking that plan. Give them lower payroll deductions. Maybe make the plan design a little bit richer. Educate them on there's a little bit more work here, but for the members that are willing to go through that extra work, you get rewarded for it. And so that's a really good way that I've seen employers get started. And then over time, you can continue to incent people to take that type of plan. But that's a good way to get started in this. Bruce, I don't know if you have anything to add on that, but those are like the 2 most common ways I typically see employers kind of taking baby steps in there.
Yeah, absolutely. The only other piece, and we're seeing it used less and less, is the physician-only side. Some people like that safety blanket. So we can create access through the Pave the Way program and that proactive outreach. But we call it a little bit of a comforter, a blanket, and get that physician-only network in, so people can see that list of providers they have access to without thinking, oh, I should call ClaimDoc and make sure that my provider accepts the plan.
Yeah, that's a good point to bring up. I mean, I think it's fair to say the abuse or the price gouging that we see is not, it's not from the individual physicians, or it's not from the specialists or your primary care doc. It's from the hospital's egregious billing practices, and that's what we're really targeting here. And so, there's some physicians only networks. I'd say the probably most common one people have heard of is PHCS, and the majority of your claim spend is going to come from hospitals. The majority of the actual number of claims is going to come from the physician side. And so if you implement a network on the physician side, you basically, eliminate those access issues, those balance billing issues for a high volume of claims, and then you target those hospitals. So that's a good point. That's a really good way to kind of step into the process. And you could even do that with the dual plan option too. Is plan option number 2 is reference-based pricing, and it's got a physician-only network. Maybe year 3 you drop the physician-only network, because the truth is too, in reference-based pricing, the physicians are getting paid pretty much the same that they're getting paid today in a network arrangement. So we don't see as many balance bills there anyway.
And DPC provides a layer of that as well, because there will be a comfort for the members and what we call an anchor where they know they can go in and be seen. We use the DPC on our plan here as well, and our members like it because they know I can go there. They don't have to think twice. And that's the challenge. That's a hurdle, as we're all, as plan sponsors look to move to a reference-based pricing and control their spend, is members, it's hard for them to change. And what they want is to go somewhere without thinking. So DPC is a nice way to provide that kind of mindless process of healthcare some of them want.